Hello, hello, and welcome back to the podcast. I'm your host. This week, I had an incredibly special guest. Now, I know I say that every week on the podcast, but this week's a little bit different. This time, I have one of my very good friends who happens to be a renowned, minimally invasive gynecologic surgeon. She's a former generalist as an OBGYN, and she's a leader in the community. This week, I'm proud to introduce my friend, Dr. Tiffany Dillard. Welcome to the podcast.
Thank you. Thank you.
So I always want to refer to you as Dr. Dillard. Make no mistake about it. You are one of the preeminent minimally invasive gynecologic surgeons in the area. You are respected by your peers, your colleagues alike, and you have probably delivered over a fourth the population of the state of Illinois. So you are definitely heavily respected, and I'm so fortunate to have you on the podcast this week. So welcome.
Thank you. Thank you. It's good to be here.
Now, before we get into this week's episode, I want to make it clear to the viewers that the information on today's podcast is not meant to be medical advice. This is a casual conversation between two colleagues, and I hope that the viewers at home can learn something from today's episode. Now, before we get started, I have to point out that you're wearing red today.
I knew it.
Now,
I knew you were going to say that. Go ahead. I'm ready for it.
Now, for those of you who don't know, Dr. Dillard is a member of the esteemed Alpha Kappa Alpha Sorority Incorporated, Ski-Wee, I know, but she's wearing the beautiful colors of crimson and cream of Delta Sigma Theta Sorority Incorporated. So shout out to the ladies of DST, AKAs, get your girl.
We are the mothers of all.
Anyway, we're gonna have to edit that out.
We are the mothers.
Make sure we edit that out. But anyway, thanks for coming to the studio today. But you're actually not from Illinois. You're an East Coaster, a New Yorker. Am I correct in that?
Yeah, I am. I'm from New Rochelle, New York, which is like suburb.
A suburb of Manhattan or a suburb?
It's a suburb of New York City.
Okay.
You know, there's Manhattan and there's the Bronx, Mount Vernon, New Rochelle, Scarsdale. So
okay, all right. I've been in New York once or twice. It's a pretty rough area, so you gotta have tough skin growing up in New York. No,
I wouldn't say that New Rochelle is exactly a rough area.
Okay.
Yeah, it's part of Westchester County. So if anyone who's familiar with Westchester County you wouldn't be too afraid.
Okay. Now we're gonna dive right into it because I'll be frankly honest. I growing up never saw any African American women who were such prominent surgeons in the community. So I just got to ask you, how did you get out of New York and become this specialist in gynecologic surgery? How does one do that? Because I have a lot of viewers at home, young women, medical students who are like, I know Dr. Dillard, she's amazing. I want to be like her. How did this happen?
Great question. My mother is a retired CRNA. And my father was a school teacher. And growing up, it's obvious that you were going to do something with yourself. You're absolutely going to, go beyond high school. And I just grew up hearing a lot of my mother's stories about the hospital and the OR. And, I even got to go with her at times. Back then it wasn't as as kind of tricky to get back into hospitals or into the operating room. So I had the opportunity to go shadow her sometimes and meet folks. And of course, she was telling me I need to be an anesthesiologist.
Okay.
And when I said I was going to go into OBGYN, she was flabbergasted. Like, why would you want to do that? But it was the right choice for me. So that's the kind of background that got me.
But that doesn't get one into medical school and get one to be a minimally invasive gynecologic surgeon. I mean, I know people that are trying to do that. I know the grades that it takes. I know the effort that it takes. I mean, your parents kind of like hard-nosed people, like you better not come home with any B's or C's. I mean, what was your upbringing growing up? I mean, were they pretty stringent that way? Or?
Good question. Actually, not really. I mean, there was obviously an expectation, but I was the last child. And so I was the good child.
Okay. I know about that.
I was the good child. I was I was just kind of naturally the overachiever in my family. And my mom will say how I came home from kindergarten and said, I'm in first grade. And she said, honey, no, you're in kindergarten. And I said, no, the teacher said, welcome first graders. So she was like, what's going on? So, you know, I went to kindergarten and they put me in the first grade because I was just naturally ahead.
Okay.
You know, same thing for 5th grade and for 10th grade. So I got ahead as a young person.
But how does that take you from sort of that stage in your life to becoming, a gynecologist and ultimately a minimally invasive surgeon? You know, growing up myself, all I saw on TV, and I hate to say it, was the Cosby Show. Cliff Huxtable was a gynecologist. I knew gynecologists. None of them were women. It was predominantly, even though gynecologists take care of women, the providers were men historically. So how did you get into it? I mean, were you watching the Cosby Show? How did you decide that you were going to do this?
Well, actually, when I applied to medical school, I ended up going to Wright State.
Shout out Wright State.
Shout out to Wright State. But when I applied back then, when you had interviews in person,
Yeah.
I remember the dean asking me what I was interested in. And I said, you know, I have an open mind. I'm pretty much willing to do anything except for OBGYN. And God laughed. So, and so actually I had absolutely no intention. I truly felt that way, like anything except for OBGYN. I didn't really want to do that. But as I did my rotations, I actually found out that I really didn't like anything. So for all those medical students that are out there, take heart. I did not like anything. I was at the end of my 3rd year and I was like, I hate it all, but I owe money and I have to pick something.
Oh, yes, I know that.
So it was a process of elimination. It was like, okay, what do I actually like? What are the things I cannot do? And then what am I left with?
But can I ask you, I mean, were your professors supportive? When I was in medical school, it was a lot of, I think you need to be a primary care physician. You can't be a surgeon. I'm not saying anything was race related, but it was just, I didn't get a lot of encouragement to go into the surgical specialties. I mean, did they support you in your efforts to want to do, OBGYN or even to go into minimally invasive gynecologic surgery? I mean, did you have support for that or did they try to steer you otherwise?
I did have support for that. Wright State is a school that has a mission to increase the number of primary care physicians, though, right? And I believe because of that, they, at least when I was there, they would accept an exceptionally large number of African-American students.
Okay.
Because a lot of us will go into primary care fields,
Sure,
right?
sure.
But as I went through and I just, I like what I like. There was no one in our school who was like, you shouldn't do this, you can't do this. Actually, the professors were all pretty encouraging.
Really?
Yeah.
Okay. Yeah. But what you do now is not what you trained in necessarily. You are a specialist in minimally invasive surgery, again, which we're going to get into, which includes, if I recall, things like robotic surgery. Right. That wasn't even a thing when you were coming through.
Did not exist.
So how did you make the leap from obstetrics and gynecology to becoming a specialist in minimally invasive surgery? I mean, did you know somebody that was doing that? Did you see like a seminar? I mean, how did you decide? Because that's really hard to do. I remember when I was in residency, I was like, I cannot figure this robot thing out. I can play a PlayStation, but I cannot figure out how to do robotic surgery. So you don't want me doing that. So how did this happen?
Well, I feel like I was blessed to come along and see the evolution of surgery in GYN. When I came out of residency, we did abdominal procedures, abdominal hysterectomies, we did vaginal hysterectomies, and we did some laparoscopic procedures, right? With just kind of what we say straight sticks. And so when I came here, because I came to Champaign straight out of residency, when I came here, that's kind of the bread and butter of what we were doing. But while I was here, these other areas evolved. So when I finished residency, there was no MIGS fellowship. There was no minimally invasive GYN fellowship. It just didn't exist. They had a pelvic surgery fellowship that was 1 year, but nothing like this. So as I worked as an obstetrician and gynecologist, I just added these things to my repertoire. And then as I, just kind of matured in my career, as a lot of OBGYNs do, I began to kind of whittle down my obstetric practice and focus more on the GYN. go from there. So it was gradual. I think it can be hard for a lot of medical students and for a lot of residents now in training because there's so many things that you can do within the field of OBGYN. It can be hard to get proficient at things.
Yeah.
You know, but I mean, I was already proficient at the basics when robotics came along.
Yeah.
So it was simple to add it.
And for the viewers at home, that cannot be overstated. You know, I remember as a resident and trainee kind of robotics coming to the forefront and having to do these sort of hours in robotic surgery. And I was just like, dude, I cannot do this. I'm like, you're sitting at a console across the room. You're kind of, it was just very unnatural for me. So I'm just amazed by your ability to be so facile with a robot and minimally invasive techniques and be just amazingly good at it. So, I mean, credit to you. You know, I just wanted to ask you if you can kind of just give me kind of just basic, you know, differences between minimally invasive surgery, because people at home are going to hear minimally invasive and you're like, what does that mean? Because I think we're all used to traditional GYN procedures. So kind of when we say minimally invasive, what techniques are we talking about? Are we talking about big incisions, small incisions? Are we talking about staying in the hospital for 2 or 3 days, going home right after surgery? What is kind of minimally invasive gynecologic surgery?
Well, traditional GYN surgery begins with the abdominal procedures, you know, making that bikini cut incision.
Nice.
Or sometimes, you know, longitudinal incision in the middle of the abdomen and going in and just doing things using your hands just directly to you know, move and cut and et cetera, do whatever it is that you need to do. That's kind of our base. The other base of GYN surgery is actually vaginal surgery.
Okay.
And vaginal surgery is the gold standard, actually, of minimally invasive surgery.
Really?
Minimally invasive meaning the least interruption in the abdomen to get in, right?
Okay.
So if we're doing surgery through the vagina, there's no abdominal incisions, which
Okay.
is awesome. And vaginal hysterectomies in some ways are a dying art. However, that's the most minimally invasive procedure. The advantage is if you have no incisions, if you have no significant interruption of the abdominal wall, then it's a faster healing time. Right?
Very nice. Very nice. So does that mean patients go home typically the same day or maybe really?
Oh yeah, absolutely. Whereas before, you know, when we were doing abdominal hysterectomies, you'd have your surgery and then go home maybe 2 or 3 days
That's
later.
what I was used to in medical school.
No.
Wow, that's changed.
Oh yeah, you got to go home. You got to go home.
You don't have to go home, but you got to get up out of here. Well, that's amazing for a lot of patients. You know, I remember, especially during the COVID period, you know, patients being admitted, you come in with one problem, have surgery, and then now you get a second problem of having COVID because maybe you have a roommate or something else. Right. So that's really amazing that your patients are able to go home shortly after surgery. I guess, you know, as I think about robotics, does that require you to have an assistant, or are you doing this all yourself? Typically, when I think of surgery, I look at pictures of multiple people kind of surrounding a patient, but I remember stopping by a robotic room and seeing the surgeon sitting across the room. I was like, "What? The patient's over here. What's going on across the room over there?" Did that take some getting used to kind of be separated from the patient? And
it did take a little getting used to. When I first started training, it was crazy. I went down to Florida to learn about robotic procedures, and there was a gentleman who would do procedures like dressed in a suit, like sitting here in a room, and the staff is in the OR, which would totally freak me out because what if something happens? He's like not actually in there.
Right.
But we are at least scrubbed and inside, you know, the operating suite. But yeah, it did take some getting used to, you know, because you kind of have this attachment feeling like you need to kind of be right there.
Yeah.
But the beauty of robotic surgery is the camera is just so sharp. And
really better than your own eyes.
Yeah, you have great visualization. You can get into small areas.
Okay.
Little corners that you couldn't get into before.
Right.
And there's dexterity along with it too, with the instruments that you use.
Okay.
So it's a finer surgery.
The women that I know that have expressed desire to undergo surgical procedures. I always talk to them about robotic surgery, but a lot of them say that their GYNs, their surgeons don't do that. Yeah. I mean, this doesn't seem like something that everybody's doing. I mean, you have to be a specialist. I mean,
Yeah, correct. And there's a whole like cascading effect, right? So depending on where you're practicing, robot time is limited.
oh,
So
okay.
if robot time is limited, then there's going to be a select few people who do it. If you are at, a larger medical facility, oftentimes the only folks in the GYN world who are allowed to do robotic surgery would be oncologists
Okay.
and minimally invasive surgeons.
Okay.
And so any cases that would require, or it could be any person who's a good candidate for a minimally invasive procedure would get referred to the MIG surgeon as opposed to the GYN doing it themselves.
Sure.
So time is a factor, and also patient skill. There's a learning curve,
Yeah,
right? So
yeah,
there are a lot
yeah.
of folks who say, I've been doing what I've been doing for years. Why should I switch over to the robot?
Yeah.
when what I'm doing is just fine.
Yeah. So I guess that brings me to kind of my last question as we kind of close out this segment before we transition. So for patients that are interested in this, I mean, is it enough if they come to me as a surgeon with a gynecologic problem to say, yeah, just go to your regular doctor, even though they don't do this? Or should I be encouraging them to at least get a second opinion with a minimally invasive surgeon to at least discuss minimally invasive options? I mean, I think of, my own family members, my mom, who has a large surgical incision from a big open procedure, and she battles with issues related to that. And I wish something like this was available to her. I mean, should patients be seeking out, at least a discussion with a minimally invasive gynecologic surgeon?
I think it's a good idea.
Okay.
There are patients that your average gynecologist would do as an open procedure because, for instance, it's like a large fibroid or so, just a large uterus. And they say, oh, it's too large. We need to do this as an open procedure. But someone who's a MIG surgeon would be like, no. We can still do this with minimal invasion. We can still do this, where you can go home the same day.
Wow,
and
amazing.
have a faster recovery. So I think it's a great idea for folks to get an opinion. And actually the thing is, to actually get that second opinion, because there are some folks who do robotic surgery but maybe are not high volume surgeons.
Oh, okay.
Who, if you go to and you say, well, can this be done minimally invasive? And they'll say, no, not really.
Yeah.
So it's if it's something that you're kind of dedicated to the idea of, then I would say it's a great idea to.
It's a great point. So to those of you out there in TV land, know your options. Know your options.
Yeah.
All right. Let's shift gears a little bit. So we talked about what minimally invasive gynecologic surgery is. What type of procedures are you doing? One of the things that I have on my notes here is uterine bleeding. What are some causes of uterine bleeding, I guess, and is this something that you address in your practice?
Absolutely. In my practice, pretty much anyone who is having a gynecologic problem.
Come see you.
Come see me.
Okay.
I don't do just like routine woman care.
Yeah. As a specialist, I wouldn't expect you to. Yeah.
I have a few folks that I've known for 2 decades or so who I still do some stuff for. But no, not as far as new patients. But yeah.
So uterine bleeding. When I think of that, I from what I know vaguely from medical school, it's kind of associated with periods, but there can be abnormal uterine bleeding as well, and so I'm assuming that that's not normal. So potentially that's something that would be treated, potentially even open or minimally invasive.
Oh yeah.
Okay.
Oh yeah. And a lot of women don't necessarily know that their bleeding is abnormal because they don't have anyone to compare it to.
Okay.
So, but if someone is having a period that seems to last more than a week, or you're having accidents at night, or having to bring a change of clothes to work,
Sure.
or having a lot of pain, it's not just bleeding. It's
Okay.
as well.
Pain as well.
Then you should get that checked out.
Okay.
And see if there are options, because there's no reason for us to be miserable. There are lots of options.
Sure. One of the things I remember vaguely is something called a fibroid, and just from what I see on TV, women, oftentimes African American women affected by fibroids, and I always thought that those patients, if they had fibroids and they were large, you just have a hysterectomy. But okay, my bad. Is that? But I guess, are there other options than just having a hysterectomy? Okay.
Absolutely. Fibroids are non-cancerous growths in the uterus, and more common in women of color, very common in African American women. If your mom had a fibroid or if your sister, there's a really good chance that you could have one as well. And they can cause bleeding and discomfort. There's some folks who have pretty good-sized fibroids who don't have heavy bleeding, though. So our mantra is, if they don't bother you, we don't have to bother them. There's some ladies who may not have heavy bleeding, but have a fibroid that's large enough that it like distorts their appearance. You know?
Oh, I
like
see.
they walk around, they kind of look like they're pregnant. They've got a pooch. A lot
That
of times
big?
they'll be, oh yeah.
Really?
There'll be folks who are like kind of lean people.
Okay.
But they look like they're, 5 months pregnant, 6
Yeah.
months pregnant because their fibroid is so big. So hysterectomy can be one source of treatment, but
Okay.
there are a lot of women now women who know that they do not want to have children, but still do not want to have a hysterectomy.
Oh, okay.
Still want to keep their uterus.
Yeah.
And for women like that, there are options. There are options to remove the fibroid and leave your uterus.
Wow. And that can be done robotically as well.
Absolutely. That's the best way to do it,
Even if the fibroid is large?
even if it's large.
Really?
Oh,
okay.
yeah.
And
yeah.
you have to make a large incision through the belly to take it out, or?
Oh, to take it out? Good question. So what we do is extend one of the incisions in the abdomen. They're all fairly small incisions, but I'll extend it just enough so I can get kind of 2 fingers through.
That small?
And then, we have techniques where we morcellate, like hand morcellate, and kind of cut it down to size and remove it.
Wow. Okay, that's pretty spectacular there. I know that there are smaller procedures that you can do too, for like tying the fallopian tubes. I guess is that not the right term? Is that a pretty simple procedure? Would you say robotically?
We don't even use a robot for that.
Oh,
To remove the fallopian, like for sterilization.
yeah.
For sterilization now, what we do is, old school, like when I first came through in training, we would literally tie the tubes, right? We would take a suture, we'd take a string and tie it around the tube and kind of knot it off and block it. But now we, the way that we do it now is to remove the entire fallopian tube.
Okay.
And you don't need to do that with robotic surgery. You can just do that with just kind of, 3 little incisions in the abdomen. That takes less than 10 minutes to do.
I see. I hear about this thing, pelvic pain or chronic pelvic pain. I always thought maybe that was associated with things like fibroids, but I guess a lot of things can cause chronic pelvic pain. What's the most common reason, I guess, that you see, or maybe a few common reasons that you see patients come in with chronic pelvic pain? Is fibroids at the top of the list, or are there other?
Fibroid would not be at the top. Fibroids
Really?
can cause pressure, heaviness, aching, but not typically. Not typically. There's always exceptions to the rule, like an ongoing pain.
Okay.
More commonly, folks have pain just because they have cramps, right? But as far as pathology goes, a condition called endometriosis is a really common, more common than you think, cause of
Endometriosis?
Endometriosis.
I vaguely remember that from medical school. I'm trying to recall all of this now. I know I'm trying to. So, but endometriosis, that's different than is that associated with fibroid? I guess it can be associated.
Not associated with fibroid.
Really, this is completely different.
Completely different.
So I guess what is that again? Is it like because I remember something about like powder burns or something? Okay, that's a buzzword. When you're at medical school, remember the buzzwords. So there's this term that, just enough to be dangerous. So I remember a powder burn. So that's associated with endometriosis.
Absolutely. Yeah,
Okay.
Absolutely. And endometriosis is when cells that are normally found inside of the uterus. So, as a woman every month, the uterine lining grows and then bleeds, which is their period.
Sure.
So when those cells that slough off typically will come out, when those cells are found inside of the abdomen, that's what endometriosis is.
Really?
And it can cause pain in that, it behaves the same way. It doesn't know that it's not inside of the uterus, right?
Yeah.
So it grows and bleeds every month.
I don't know why I feel like every time I hear or think of endometriosis, I think of African American patients. Is this something that's more common in African American women, or is it kind of from your practice, from what you've seen, equally distributed? Maybe
I was equally, or I actually probably see more non-African American.
Really?
Women. Practically, I
Okay.
see more non-African American women, and of course there could be many reasons for that.
Sure.
Especially since most I won't say most, many African American women have to be like damn near dead to go to the hospital.
Yeah,
right?
unfortunately.
A lot of times we'll put up with things.
Yeah,
We'll put up with pain, we'll put up with bleeding, and then by the time we present or mention it to, your doctor, then it's like, it's been going on for a long time.
Wow.
So there are a lot of folks who will put up with stuff.
Yeah. Is endometriosis a reason to undergo surgical treatment, minimally invasive treatment? I mean, can you treat that surgically?
Yeah. You
Okay.
can. And actually, the only way to truly diagnose it is to do surgery.
Oh, really?
So if ladies are having, pelvic pain, especially like monthly pelvic pain, and we're, maybe try some of the medications, maybe birth control pills, et cetera, and it's not working, then having surgery to diagnose the problem can be helpful because, you want to know why.
Sure.
You want to know why someone's in so much pain. So when we do that to diagnose it, then we can also remove it if we see it.
And you assuming you can do this minimally invasive
Absolutely.
as well. Yeah, I'm so sad, and I have a good friend of mine who has endometriosis, but she was diagnosed via a relatively large incision on her midsection. I only know this because she came to me as a plastic surgeon wanting to know if there are interventions or treatments for that. But it sounds like that can be done through relatively small incisions, so patients don't have a large traumatic scar. So
better. It's actually better to do it.
I wish more people knew about that. I think sometimes people hear about robotic surgery like, oh my gosh, the robots are taking over. So
Right.
so they kind of shy away from it. But this is a way to actually get back to normal activities much faster, much easier.
Oh yeah. So, I rarely have a patient who spends the night in the hospital. Rarely.
I'm blown away by that. I really am.
Yeah, rarely have a patient who spends the night in the hospital. Whether the uterus is removed or endometriosis is excised, you wake up, you go home.
Wow.
You go home and folks are good. You go up and downstairs, you eat and drink what you want.
I feel like that's a bad thing for some women. I feel like sometimes I see women in the hospital and they're accompanied by their husbands. Their husbands say, when can my wife? And I'm like, no. Like, so maybe we need to keep some patients in the hospital, keep them away from their kids and their family for a few days so they can recover. Now, the other thing I think I remember is I know that you have some experience with menopause. And the only reason I mentioned that is because my mother all the time, talks about her energy level being low, and this sort of coming about after menopause. Mm-hmm. I guess for those who don't understand, what exactly is menopause? Because as a male, I don't know that there's a male equivalent of a menopause, and so
I don't think so. Yeah.
I guess I don't know much about it. So what is menopause? When is menopause?
Great question. Menopause, like by definition, is when a woman has gone 1 year without having her period once she's of, around 50 years old or of menopausal age, right? So you're born with all the eggs, women are born with all the eggs they're ever going to have. And, you're knocking them off every month.
Okay.
Right? And so you get to a point where
that's their period, I guess.
With their period.
Okay.
Right? And so you get to a point where your reserve is so low and basically your ovaries are like, and I'm done. So as that hormone level is decreasing, ladies will start to experience menopausal symptoms. And once that hormone level, their estrogen level gets down to a certain level, then they'll start skipping periods. Sometimes they can be irregular before they stop as well. But they'll start skipping periods and eventually they'll go a whole year. And once you've been a whole year without a period, then we say, it looks like you're menopausal. We don't expect you to keep bleeding once you've been a full year.
I see. So this has nothing to do with childbirth or pregnancy.
No. As far as the timing of it,
yes,
as far as
the timing of it.
No. I mean,
do you hear that, Mom? I have nothing to do with your symptoms of menopause. Dr. Dillard has said it, so please stop shaming me and guilting me. Thank you. Okay, doctor, carry on, please. Okay. So, can you tell me, is menopause always treated surgically? Is it not treated surgically? Are there any things that, as a provider, you can offer women that are going through menopause?
It is definitely not treated surgically.
Oh, okay.
Definitely not.
Sorry, I don't know much.
No. That's fine. Because hormone levels are low.
Okay.
And so we don't need to, do anything physical to a woman to change that.
Okay.
So it's treated with medication. It can be treated with medication. It can be treated with actually like behavioral therapy, mindfulness, even.
Okay.
Some folks, feel like by changing their diet, it can make some differences because it all depends on the symptoms that they're having, and ladies can have a wide variety of symptoms.
Okay. So it just depends on the symptoms, I guess, which dictates how you treat it. I guess typically I hear about kind of early menopause. Is that a thing? Would early be like before 50, before 60? Is that something that's becoming more common that you're seeing?
What I'm seeing is that women are understanding more about menopause and are recognizing it sooner. So average age of menopause is 51.
Oh, wow.
Average age of menopause is 51, but you can begin to have symptoms 8-10 years before.
Okay. Okay.
So it's not considered premature menopause unless it occurs before 40.
Okay. All right. Fair enough.
So yeah.
So I guess as we think about, or as I think about women's health, what are some things, I guess, kind of as we close out today's segment, for the viewers that are tuning in at home, what are, I guess, some basic maintenance things that women should be doing? I know that there are things called pap smears, and that can pick up certain things, but it wouldn't pick up things like endometriosis or fibroids, et cetera. But that's something that women should routinely be doing?
Absolutely.
Okay. And what age does that start?
So we start doing pap smears at age 21.
21. Okay.
21. Yeah. Previously it'd be 18 or with sexual debut,
okay.
I would say. But now it's age 21 is when you start doing pap smears. So every woman should have a pap smear at regular intervals.
Okay.
As well as a breast exam.
Okay. And is so that's kind of routine surveillance. Is there any routine surveillance for some of the things that we talked about before, like for endometriosis or fibroids? Is this something that women should be checking also, in addition to routine pap smears?
There's no routine surveillance per se for endometriosis unless you present to your physician and say you have symptoms. However, with fibroids are often detected with a pelvic exam at the time of a routine visit.
I've talked to some people who believe like holistic approaches, to reduce fibroids, chronic pelvic pain, et cetera. Have you heard of things like this? I don't even know of any examples, but I know a lot of people are like, I don't want to go to the gynecologist. I don't want to go and be seen by a minimally invasive surgeon. I want to take care of my issues holistically, whether it's supplements or other things, meditation. I've even heard some women using needle acupuncture for pelvic. Do those things work? I guess, is it patient dependent? Works for some, not for others?
It's everything can have a placebo effect.
Sure. Oh, placebo. Sure.
Right?
Sure.
So what I'll say is beyond, some things like acupuncture or certain vitamins, there are no, randomized controlled trials that would say that they work, but some things work for anyone, right? So I feel like, if someone is wanting to avoid medication, then, just make sure if you're doing some sort of alternative therapy, make sure that you don't have any other health problems, that you probably shouldn't be taking something, but go for it because it just might work, and, even as mindfulness, if you believe it will work, maybe it will work.
Fantastic. Before we close out today's episode, I cannot close out today's episode without commenting on the fact that you are an incredibly successful surgeon, wife, and a mother of two incredibly talented kids. And I do have to ask you, how did you balance all that? Because being a surgeon is hard. Sometimes home life is neglected, but I know your children and they are incredibly successful. How did you do it?
I have a very supportive partner.
Okay.
I have a very supportive partner. So yeah, my husband holds everything down at home. He's the go-to person.
Fantastic.
So yeah, so my kids rely on him heavily.
Well, shout out to him. Well, as we close today's episode, are there any parting words that you want to give to viewers out there who may be wondering about pelvic issues, gynecologic issues, or even their options if they need surgery? Any thoughts to those people out in the internet land who will be watching this episode today?
Yes, folks out in internet land. I think it's important to know that women now in 2024, going to 2025, we have choices and we have options. And so if there's something that you're living with that you don't want to be living with, then reach out, talk to your doctor about it. Find ways to change things. My mother's generation, the whole baby boomers, et cetera, they lived with so much, they tolerated so much. And today's woman is realizing that we don't have to. If you're having menopausal symptoms, well, then you need to go to the doctor and get it figured out. See what you can do. There's a lot of living to do. And if you're going through menopause at age 51 on average and having symptoms as early as 43, 44, and hopefully your lifespan will be 80s, 90s, that's a lot of time to live miserable. No need to do that. So whether it be menopausal symptoms, whether it be pelvic pain, whether it be abnormal bleeding, whether it be painful intercourse, you should absolutely go and talk to your doctor about it, because there are interventions that the majority of the time can make a huge difference.
That is fantastic advice. And before I close, I just have to say, shout out to your stylist. You are dressed impeccably. Joella Jones, if you're watching out there, you told me to come in with my A game. And I wore some slacks in this shirt, but Dr. Dillard came with her A game. So I need to do better. As a plastic surgeon, let me apologize to those watching today. I'm going to do better as your plastic surgeon. So until next time, thank you, Dr. Dillard, for stopping by. And to those of you watching, thank you for tuning in. Until the next episode, peace.